Now, recent guidelines advocate the use of 4 pillars of pharmacotherapy for heart failure. What are the 4 pillars? And in real life, do people actually get 4 pillars?
If you have the dominant version of heart failure, which is the heart failure because of LVSD, so left ventricular systolic dysfunction, this is where we know that there's 4 main classes of medicine that improve your survival chances and decrease things like your readmission to hospital risk, and also improve the signs and the symptoms of the clinical manifestation of the syndrome of heart failure. So we know 4 main drugs do this, and they are essentially something called a RASI blocker, which is either an ACE inhibitor, an angiotensin receptor antagonist, or something called an ARNI. So that's one of the 4. A beta blocker, SGLT2I, and an MRA. So there's 4 different drugs that all work in a different pharmacological pathway to improve the syndrome of heart failure. Now, they all work mechanistically differently, and they're all additive in their benefit. So the important thing, and they all slow the progression of the disease. So the important thing is that we probably get on to patients, them onto them as quickly as possible, assuming that the patient consents and thinks it's in their interest and chooses during this shared decision-making process to accept the treatment. Then we like to try and get them on as quickly as possible.
So what about the sequencing, the order in which the drugs are introduced?
Now, the order in which you go probably isn't as important as to really trying to get people onto them as quickly as possible. And we try and tailor the approach to the individual in front of you. So perhaps, for argument's sake, if your blood pressure was higher, we know the medicine called an ARNI drops the blood pressure the most. Perhaps if you were diabetic also, the SGLT2I is also diabetic medicine, so it might be good for that. Perhaps if you had a new heart attack and you damaged the ventricle, then we know sometimes the one called an MRA, a medicine called eplerenone, is a good at that stage. Perhaps if your heart rate was high or you had some angina pain as well, perhaps the beta blocker might be the best thing to do. So we have to look at the patient in front of you and look at what the risks of that individual patient are, and to understand them and their kind of unique constellation of signs and the symptoms. And that maybe then it lets us make some kind of judgment on what order to get you onto these 4 pillars. We used to do this in a certain order, and that certain order, if I'm being honest, causes a lot of inertia, where you say, okay, it must be A, followed by B, followed by C, followed by D. And often in the treatment plan, this takes many, many months to do. And often a lot of people, through just burdens of health service, kind of get missed and probably don't get onto all 4 pillars. So we probably are quicker now in 2023 of trying to start these medicines than we were maybe 5 years ago. And it's more about trying to get them on, as quickly as possible while still treating the person as an individual, and finding this balance between speed, which is good, but also patient-centeredness and helping them understand this complicated treatment pathway and making this shared decision between us. So it's very easy for me to write you a prescription and send you away with probably 2 or 3 of these drugs on the first day. It's hard to do that while I've still educated you enough to understand them all. So it's trying to find this balance where we have a team-based approach with medics, with nurses, with pharmacists, with different team members that can quite intensively and quickly see them in this first few months of treatment to try and get them onto all 4 of these drugs. I think most of us don't really care of the order you go onto them now, as long as we treat you as an individual and trying to get you to them on over this first few months.
If my memory serves me correctly, this used to be different. There used to be an ideal order for starting the drugs.
So what would happen in the olden days is they would say, give you an ACE inhibitor, then a beta blocker, then an MRA, then scubalsaltine, then an SGLT2. But if you work in somewhere like I do in Glasgow, in inner city Glasgow, it's quite a deprived area. And a lot of patients, through lots of complicated socioeconomic factors, sometimes fall off a treatment pathway kind of track, And also health services are very, very burdened. We know this, GPs, hospital services are all creaking around the edges. And so when you go with that A, B, C, then D type of approach, it takes a lot longer than actually starting a couple quite quickly and then adding the others in and then tapering the doses up as you go. So over the last few years, our international guidelines and some of our local guidelines really have flipped to trying to get these 4 drugs started at maybe a lower doses as quickly as possible, and then do the nudging with the doses rather than maximize one to the top and then the next one to the top and then the next one. We have really flipped this over the last handful of years.
So how do you ensure that people reach the optimum dose for each pillar?
From the fundamental evidence that gave us the results from the seminal trials of each of these medicines, we know what the optimal dose in an ideal world should be, and we call this in heart failure and other conditions the target dose. Now, we often, with a lot of the medicines, start at a slightly smaller dose and then build them up over time. So as we go through these first fundamental months of treatment, we have to try and tailor that treatment again to the individual in front of you, and that requires us to see them fairly regularly at clinic or over the phone or remotely if you can do that now, and we have to look at things like blood pressure, heart rate, kidney function, other blood test results, how they're feeling as well. As we get you onto these therapies, hopefully your symptoms of heart failure will be better. But unfortunately, we know that all drugs to a certain extent cause side effects and adverse drug effects in certain patients. So sometimes when we scale drugs up, people feel the side effects of them. And it's trying to balance, again, the benefits that we're giving people versus the risks and the problems. So it's a mixture of seeing them regularly, checking a number of vital signs and clinical parameters when they come back to clinic, asking them how they're feeling, asking them about side effects, continuing to have this shared decision making throughout the length of the of the initiation of these drugs. Because I might say to you in visit 1, Christine, I think this drug will help you, it'll make you feel better. But maybe when I start you on it, maybe it doesn't. Maybe it makes you feel worse. Maybe it reduces your quality of life. Maybe you change that decision about whether you want it or not. So it's a mixture of, yes, quite cold therapeutic things about numbers, but also talking to the patient and looking at their quality of life and symptoms, while trying, where possible, to get them on to the dose closest to the target dose in the seminal clinical trials that we can do, because that's the dose that we know from the evidence that prevents the type of things like future heart failure events or improves things like survival. So again, this is a complicated kind of moving dynamic. And that's why it's quite labor intensive. And that's why, it takes a long time to get people onto full treatment, or sometimes people stall and, don't quite get there because it's labor intensive. And this is why a team-based approach with lots of different stakeholders is probably the better model for doing it.